Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Madhav Makashir, gastroenterologist at Dr. Prem Hospital, Panipat, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello, my name is Dr. Madhav Makashir. I'm a consultant gastroenterologist practicing in Panipat.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So, IBS stands for irritable bowel syndrome. It's a multifactorial syndrome, which it is basically a chronic disease characterized by pain abdomen, and the pain abdomen has to be associated with disturbed defecation.
Is IBS really a stress disease, or is there more to the story?
No, IBS is not merely a stress disease. There is definitely more to the story. Stress is a component of the multifactorial pathogenesis. IBS has various factors that are involved in the pathogenesis, such as visceral hypersensitivity, gut microbiota, gut permeability, low-grade gut inflammation, diet, genetic factors, and of course stress and psychological factors are also involved.
What are the top 3 red flags that make you suspect IBS in a patient?
3 things that make me suspect IBS is: 1, it should be a chronic disease. Number 2, there should be pain abdomen. Pain abdomen is a characteristic symptom, and the pain abdomen should be associated with altered or disturbed defecation.
What simple screening questions can a consulting physician ask to suspect IBS?
So these 3 things should be present. Firstly, in IBS, it is a chronic disorder. It's not a new onset phenomena. Number 2, pain abdomen should be there. And number 3, the pain abdomen should be associated with disturbed defecation. And most important is to rule out the alarm features such as bleeding per rectum, anemia, unintentional weight loss, vomiting, occult blood positive, or new onset symptoms in an elderly male. These are alarm features that one should exclude before making a diagnosis of IBS.
How important is the patient's history compared to investigations in IBS diagnosis?
So patient's history is the most important, first and foremost. It should be a chronic disorder associated with, there should be pain abdomen, and the pain should be associated with disturbed defecation as per the criteria. And along with the history, we should do a thorough physical examination, including a digital rectal examination, with some amount of limited investigations can be done, such as blood count, CRP, celiac profile.
How do you apply the Rome 4 criteria in day-to-day practice? Can it be simplified for general physicians?
So basically, Rome 4 criteria states that for a diagnosis of IBS, we should have pain abdomen that should be at least 1 day per week for the last 3 months, and the onset should be at least 6 months prior to the diagnosis. And the pain abdomen has to be associated with 2 out of these 3. Number 1, pain should be related to defecation. Number 2, change in the frequency of stool. Number 3, change in the form or appearance of stool. To make it simple, patients should have these symptoms for at least 6 months. It should be a chronic disorder. It should not be a new onset phenomena. And patient should be currently symptomatic. It's not like patient has had symptoms in the past and now he's presenting. No, patient should be currently symptomatic. Number 2. Number 3, 2 out of these 3 things should be present, as I mentioned, such as the pain should be related to defecation. Pain should be associated with increase in the change in the form of stool, or number 3, pain should be associated with change in the frequency of stool. 2 out of these 3 criteria should be present.
How often do you see IBS overlapping with anxiety or depression, and how do you address it?
So IBS is very commonly overlapping with anxiety, depression, and somatization symptoms, and this requires a multimodality management. You need a gastroenterologist, patient should be counseled properly, a counselor may be needed, and sometimes psychiatrist and psychotherapy may also be needed. So it requires a multimodal therapy.
Once IBS is diagnosed, what is your first line approach to management?
So, first line approach to management is, of course, dietary changes in lifestyle management and compounded by some amount of pharmacotherapy if needed.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
So, treatment of IBS is predominantly symptom based. So, it depends on whether the patient has predominant diarrhea, whether the patient has predominant constipation, or whether the patient has predominant pain. If the patient has predominant constipation, then you can give psyllium husk or polyethylene glycol or other agents such as lubiprostone, glucalopride. If the patient has predominant diarrhea, then you can use loperamide, you can use tricyclic antidepressants such as amitriptyline. And if the patient has predominant pain, then you can use peppermint oil, antispasmodics, SSRIs, tricyclic antidepressants.
The most common mistake you see in IBS management?
The most common mistake that I see in IBS management is that doctors often tell their patients that you do not have an illness. You're neurotic. This is a psychological disease, and I think that is wrong. It's an actual illness. It's a syndrome, multifactorial syndrome, and the patients are actually suffering. So this syndrome needs to be dealt with care and caution.
One food you tell IBS patients to avoid?
So I normally tell my patients to have a healthy, balanced diet and to avoid aerated beverages, junk food, fatty foods, and of course there is some role of low FODMAP diet as well.
One myth you'd like to bust about IBS?
So one myth about IBS is that it is not an actual illness. People, doctors and patients' family alike, they feel that it's a neurotic, patients are neurotic, patients are feigning their symptoms, it's an imaginary disease. That is not true. It's an actual syndrome. In fact, it is called a disorder of gut-brain interaction. And that is why it needs to be dealt with care and caution and compassion as well.
What's your gut-friendly morning habit?
To each his own, but my gut-friendly morning habit is I like to have 2 boiled eggs in the breakfast every day, and I feel that is good for the gut health, but to each his own. Thank you.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.